Brooklyn Independent Television.
Coming up on Healthbeat Brooklyn.
When is your first concert?
No matter how old you are, good hearing is an important part of staying healthy. At Kings County Hospital, we show you what an exam looks and sounds like today, and what could be at stake.
There's estimated to be 60 million people in the United States who have hearing losses that would benefit from either hearing aids or other forms of intervention.
Elder care. A geriatrician talks about how caring for seniors could be handled much better, starting with the problem of too many prescriptions.
And she was on 15 medications.
15 medications.
If you went back 6-7 years, 95% of these guys look like good Orthodox kids, going to school.
But most of these young men have gotten involved with drugs or alcohol. In Midwood, Our Place offers them counseling, training, and an alternative to the street.
And when they're in here, we have them. And we can start working with them.
And a newborn baby. Sure, it's wonderful, but...
You're totally overwhelmed.
And in those first few weeks, who has the energy or time to cook? The women behind Meals for Moms, that's who.
Not too much, but amazing. Here you go.
All this and more on Healthbeat Brooklyn.
Welcome to Healthbeat Brooklyn on Brooklyn Independent Television. I'm Dr. Monica Sweeney. For almost all of us, a life of silence is unthinkable. But still, we tend to take our hearing for granted. We're aware of protecting our eyes. We'll buy a pair of cheap sunglasses. But what about our ears? Maybe, just maybe, we occasionally turn down the volume on our TVs or iPods. Just as we need to get annual physicals, and yes, our eyes examined, we should also have our hearing checked. If it's been a while, here's Healthbeat's Caroline Shin to tell us what to expect.
There you go. Okay, so come and sit, Mommy.
Whatever you want to do.
Now come and sit. Come and sit. There you go. I'm going to do a hearing screening on your baby today. We saw the baby in the nursery, and he did not pass in the nursery. That does not mean the baby has a hearing problem. Okay?
The most common illness that we deal with in hearing is hearing loss. It happens at different ages with different people. If you have a parent that lost their hearing and started losing their hearing at a young age, chances are you will as well.
And what this test does, essentially, is it's looking at the brain waves as the baby's listening to sounds. And every time a sound goes into his ear, we want to see the brainwave change.
There are two types of hearing specialists that evaluate hearing. There's the audiologist and the otolaryngologist, or ear, nose, and throat physician.
Audiologists are non-medical people, but we are trained to recognize diseases of the ear and pathologies of the ear. So after we get done with the test, of course, when we see a problem, anything that's suspicious that it could be medical, we're going to refer to the ENT physician. Here we go. Good. Here we go. And this one. There you go. And we have little baby earphones. Wait, it's your first concert. It averages out to be roughly 3 babies in 1,000 are born with hearing impairments, permanent hearing impairments, either in one ear or both ears. Congenital hearing loss is now the #1 birth defect in the United States. If we catch them really early and we start the intervention early, which could be hearing aids, it could be speech therapy, it can be a combination of both, they will develop language and academic skills equivalent to their hearing peers. But it has to be early. It seems like the babies that are caught after 12 months or 18 months, they just never catch up. So it seems like he hears great in both ears. He can hear you. I can't promise you he'll listen to you as he grows up, okay? So that's it, you're all done.
There's estimated to be 60 million people in the United States who have hearing losses that would benefit from either hearing aids or other forms of intervention, but less than 15% of those patients ever seek any treatment for it.
I can't tell you how many couples come and say, well, why are you here? Well, my wife says I don't hear. And you're actually wind up being a marriage counselor practically. Okay, Miss Payne. We're going to start the standard part of the hearing test.
Okay.
I feel that people should start getting their hearing screened for age-related hearing loss probably in their 50s. But if you don't have any history of hearing loss in your family, you can probably go a little later. There are other things that affect it, smoking, diabetes, noise exposure, things like that.
Adults, we like them to hear from 0 decibels to 25 decibels, dBHL. And children, we like them to hear from 0 to 15 decibels. And the lower the number, the better the hearing.
Oftentimes, if you're wanting to listen to your iPod and you're on a subway where the platform is at 100 decibels, you're going to turn that thing up to 120 decibels so that you can hear it. And that's very damaging to your ears.
Good, very nice. Now I'm going to ask you to say some words after me. They'll start loud, just like the tones did, and they'll get softer and softer and softer. Sidewalk.
Sidewalk.
Airplane.
Airplane.
Baseball. We tend to lose our hearing in the high frequencies first. And in English, the high frequency sounds are S, F, T. So you're not going to lose the hearing of all your sounds equally or globally across the board. Think of the sentence, you can go, you can't go. T carries all our negative, the negation in English. It's a huge difference in meaning. This is also emerging as technology where we can differentiate if a hearing loss is sensory versus neural. And the hearing aids are getting quite good now. We're not running into the problems where people are overwhelmed with the sound like they were when we were using analog technology. I'm also very big on what we call assistive listening devices or assistive communication devices. You have any questions?
No, I'm good.
Did it hurt?
No, comfy.
Okay.
Yes, I'm good.
Okay.
All right, I'm good.
You got it.
Okay.
I always want people to hear better, but at the end of the day, what's important is that they communicate better.
As a nation, we are, to put it bluntly, getting older. The youngest members of our largest generation, the baby boomers, are just turning 50, while the oldest are now senior citizens. That means more Americans will be moving into old age at one time than ever before. And yet geriatric medicine is not getting the support and attention it needs to keep up with demand. Here to talk about both the attitude toward elder care as a whole, and more specifically, changing the way it could be practiced, is someone who treats the elderly on a daily basis. Dr. Mudannayake is the medical director of the Cobble Hill Health Center. Thank you for being with us. It's good to see you.
It's a pleasure to be here.
So how big a problem is not having the staff, the geriatricians that are trained adequately with this burgeoning baby boom?
It's a huge national problem, and it's a problem that needs to be taken very, very seriously in the light of the new Affordable Health Care Act.
How is that going to impact it?
Well, we're looking for ways to improve quality of life and reduce cost at the same time. And I think
it's a tall order.
It is an order which would appear to be very tall, but I think there are a lot of areas where we're doing unnecessary things and unnecessary procedures on people who really don't want them. A simple way of looking at this, if you have a child who's having a fever of 104, you'd certainly want a pediatrician to look at the child.
Correct.
But what about elderly Mrs. Smith, who's 98 years old? Wouldn't you want a geriatrician looking at her?
Appropriate care by someone appropriately trained is what we need. And we're not doing it.
We're not experts at the management of chronic diseases. And this is what all of it is about. And part of the reason is the way the reimbursement structures are structured. And the other real issue is people just don't want to do it.
Well, there's not a lot of people who get a lot of enjoyment out of taking care of somebody who's going downhill and the eventual outcome is death. But it can be very rewarding because I practiced geriatric medicine before coming here. So what can we do to remedy this problem briefly?
A lot of it has to do with the cultural context that people find themselves in. Aging is a perfectly natural process. In some areas in the world, you have very little population who are actually sent to nursing homes. You have what we call successful aging, where you can have a 106-year-old climbing an apple tree and plucking apples. Now, I'm not advocating for 106-year-olds to start climbing apple trees.
Well, we don't have that many apple trees in Brooklyn, so.
I think institutionalization is something which should only occur when there's no social support systems in the community to look after these people.
And that's what we need to work on.
And it's a very, very big issue, to have families understand that elderly play a really pivotal role in terms of the experience, their life experiences, and how they can play an active role in family, in day-to-day running of families.
But you know what I want you to tell me? I want you to give me a concrete example of something that's happened to one of your patients, which you take care of the elderly all the time, as a result of this lack of appropriate care.
Absolutely. I'll shorten her name to Mrs. GP, and GP doesn't mean general practitioner, by the way.
Okay.
This is lovely, lovely elderly lady who's two nephews. She was looked after by two nephews. Had taken her to see a physician, and she was on 15 medications.
First problem, 15 medications.
Well, you have this concept of what's called polypharmacy, and it's really a very simple concept. Poly means too many, pharmacies, medications. And so you have to go back to the basics and look at the risks and benefits of each and every medication and the drug-drug interactions. That's the interactions of those medications.
I want you to explain something to the audience, because many people that will be listening to us will not consider the aspirin that they're taking, the Tylenol that they're taking, the omega-3 oils that they're taking, the Dulcolax tablets for their bowels. If the doctor doesn't write a prescription for it, they don't think it's a medication. Would you address that?
I think the use of over-the-counter substances and medications is families who are taking care of these people, and these elderly people themselves have to realize that they do have adverse effects. They do have drug-drug interactions. But what I'm initially far more concerned about are prescribed medications, which these people are on. I remember the classic example when I was doing my fellowship in North Shore, and my mentor took me to see this little old lady who lived in the community. And he said, when I found her, she was eating cat food. But she had her calcium channel blocker. She had her, a whole bunch of expensive medications. So what were we doing? Prescribing medications where the woman couldn't afford these medications. You have drug-drug interactions where you get one medication that's prescribed by, say, one specialist, say a urologist, just for an example. Another specialist comes along, he's a neurologist, and he prescribes this. A third specialist, who's a cardiologist, prescribes that.
So back to Mrs. GP.
And so Mrs. GP was one of these who was on 15 of these medications. And so what I did is I looked at each of the medications in terms of risk-benefit profile and in terms of interaction with the other medications.
Was she symptomatic in any way from the polypharmacy?
I believe that she was what I considered to be schlogged. Schlogged was out of it.
Out of it.
And she had a family that really adored her in every sense of the word. And we got her off a lot of these so-called unnecessary medications, which were probably causing sedation and other adverse effects. And lo and behold, she started eating her tuna fish with a fork. Now, that really had big impact on the family because it was something that hadn't been there for the previous 6 months.
So you, by going through the medication, taking off the ones that she didn't really need, you improved her quality of life, including her activities of daily living.
Absolutely, and that's where functionality comes in. When you're a geriatrician, you focus all the time on the function of the person. What are we doing, giving this woman an expensive lipid-lowering drug? She's 92.
Yes.
There's no data to show that it actually prevents either primary or secondary coronary arterial disease. And she's anorexic. She's not eating. There's a reason why she's not eating. She's on drugs that suppress her appetite. That being one of them. And it's also quite expensive. She has a copay on that.
When someone suspects that a medication is the cause of their problems, would you, in the time we have left, tell the families and the patients who are listening what they should do? What steps should they take if they think a medication's not agreeing with them?
The first thing is they should write down what is different. So mother is more sedated. Mother was throwing up. Mother's constipated. Constipation is one of the biggest problems for the elderly that's simply not addressed, and it really reduces their quality of life. Mother, mother looks flushed. Whatever it is they're seeing, write it down, not in medical words, but in their own words. Call the healthcare provider, whoever it is, and say, look, you started mom off this medication, and they could probably read off what the medication is, and we're experiencing this right now. They should certainly respond, or a nurse practitioner or somebody in the office, well, you should talk to Dr. So-and-so about this.
Unless it's an acute problem, and then they take them with all the bags of medication. And go
Absolutely. I mean, one of the most important things being a geriatrician is asking people to come in with this bag of medications, because they've been taking these for years and years and years. They're beautifully arranged in the most magnificent, sometimes ivory, sometimes plastic pill boxes, and they don't need to be taking them.
And they don't need to be taking them. We're going to have to leave it there. Dr. Mudannayake, thanks for being with us. From one generation to another, young people raised in strongly religious cultures usually tend to follow their community's rules. But when they do get into trouble with drugs or alcohol or even minor crimes, how much understanding and support do they get from that community? Or are their problems overlooked, even suppressed? In Midwood, one organization exists to offer a safe haven, everything from a pool table and a free meal to personal counseling. Its clients, young people from the Orthodox Jewish community.
Our place is simply a place where a kid can come and hang out and be who he wants to be and not be judged.
A place like this is really a home for teens that don't have a place to go or otherwise would go to the local pool hall or the street corner where 7-Eleven may be, and get in trouble.
If you went back 6-7 years, 95% of these guys look like good Orthodox kids, going to school and have the yarmulkes on their head and wearing the Orthodox clothing and just doing regular normal life. And over the past several years, they've strayed from the religion and strayed from their families.
What we have today is really a phenomenal center for Jewish teenage kids in the Flatbush, Brooklyn area, neighborhood. These are kids that for whatever reason they're out on the streets and they can't go home, or they could go home, but it's just rough in the house. We built this place and said, hey, you know what? Let's let them come here and let them do their thing here.
It's a good place to chill, I guess. I don't know. They got pool. They got everything. Workout. TV. You can always just come here, grab a bite to eat, relax, hang out with friends, in a comfortable environment.
There's a tremendous amount of denial in the community, and just a tremendous amount of denial in general of parents of kids that are dealing with this stuff, dealing with substance abuse and dealing with addictions. Meaning, in order to maintain the integrity of the community, they need to have a certain sense that if you're not doing what we say you do, you cannot be part of the community. That is how any community exists.
As many as 150 new members attend in any given month, and the organization as a whole deals with between 700 and 1,000 or more members annually.
The services we offer is counseling, individual counseling, group counseling, and drug counseling with professional drug counselors and social workers that are on staff. Another service we offer is a form of trade school. We have wood shop, and electric shop. One of the services we offer is job placement, which includes job counseling and career counseling. We have a school during the day, an alternative high school, which helps kids get either GED or Penn Foster, which is at-home school, where they can get a high school diploma.
What do you think about this place, Robert?
This place is the best. You got the best guys.
This. Yes. Thank you.
You're talking about me, rather, right?
We know one thing: we're never going to beat the streets. The streets are sugar for a kid. I mean, they have everything out there that they today what they want to get. So what we said is that, the only way we're going to draw them is let's give them the best of everything that we can and strive to be the best number two. So we're going to give them hot food. We're going to give them a gym, a music room, pool tables, big screen TV to watch sports, and a lot of great people to come and socialize with and talk to.
We've done trips to the Ukraine, Europe, Israel, skiing in Vermont and New York, upstate New York, boating, fishing.
We give whole life therapy to these kids. We don't just stop and say, hey, is it your drug issue? It's a family issue. It's a school issue. So we kind of take that kid and we mold them and say, what is it that you need? And fit them in and try to get them back into their social standings of where they've been in the past, or where their family life has been before they fell into these tough times.
The community sort of needs both sides. They need to have this hard line to maintain the community, and they need our place to catch everything that falls out of that hard line. And if we work together, it'd be very, very powerful. The ideas and the model that we've built in our place are universal ideas. A kid to leave his community, to leave his society and go start doing illegal and illicit behaviors has to be hurting. He has to be feeling pain. He has to feel like he's outside of a family and outside of a community. The reason why gangs flourish is because a gang says, come here, be part of our family. The reason why people join the army is because the army says, come here and be our family. The reason people are suffering is because they want a family. And it doesn't matter if you're part of the Orthodox community or part of any other community. If you're suffering, you need a family. And this center is an extended, healthy family that they could always join and know that we're here, and that works for everybody. This is not a Jewish center. It is a universal center.
And when they're not out there, they're in here. And when they're in here, we have them. And we can start working with them. Now, not every kid wants to be talked to right away, and not every kid wants to work forward. And we watch them, and we see their slide, their fall. But when they're ready, they'll say to us, hey, you know what, I got to get my life together, and I got to get my, everything in order, and I got to move forward. We're here for them. And that's when we'll pick them up, and we'll say, okay, what is it that you need?
A uniquely Jewish thought is to save one soul is to save a world. To save one soul is to save an entire world. And that's what we believe down here.
For a woman who's just had a baby, joy and exhaustion go hand in hand. Maybe the only thing she wants to do is spend time with her baby. But how much energy does she really have for anything else? Like cook a real dinner, for example. That's where the women in this story come in. Brought to us by Healthbeat's Tati Amari.
It's a very raw and kind of amazing time in your life. And you're really tired, you're really kind of hormonally all over the place.
Most new moms would describe postpartum the same way.
And you're totally overwhelmed.
But what if you had someone to jump in with a little help?
But to have another mom show up at the door who's got a smile on her face and is ready to kind of ask you how you're doing and show up with a nice hot meal takes the load off.
Nicole Fabry had that help after she gave birth to her son 4 years ago.
It was wonderful.
So when she moved to Brooklyn from Michigan, she brought the concept with her.
And right now I'm making a salad for her. Just gonna chop.
And Meals for Moms was born.
All the neighbors are, talking. Oh, my neighbor's pregnant. My friend is pregnant. I've been known to walk up to ladies in the store who are pregnant and say, do you live in the neighborhood? Because You know, we've got this kind of fun program. You might want to join our club.
There are about 40 moms from the Prospect Lefferts Gardens neighborhood who are part of the group, and it works like this. When a mom gives birth, a team will cook her about 16 dinners over 6 to 8 weeks.
So this is a whole chicken. It's kind of like my signature dish. It's a whole chicken with a lot of root vegetables. It's got red beets in it and rutabaga and turnips. We have moms from all over the world also, so we get kind of a wide range of ethnic dishes. We have some Korean moms, Japanese moms, Indonesian.
Variety is the spice of life, but for Nicole, nutrition is key.
Somebody said something about they joked about delivering McDonald's to a pregnant mom, and I was like, no. This is a home-cooked meal. This is like focus on nutrition. It's focus on what a new mom needs. It's all stuff that I make at home. It's what I would serve to my own family.
Anna Ruggieri of Long Island College Hospital says that Meals for Moms is on the right track, and she gives similar nutritional advice to her patients.
They'll eat whatever they can find in the cupboard, because these mothers, being that they're taking care of this little person, they're not taking care of themselves. And you need your nourishment to do that, to help you with the milk supply, to help you with the healing, and to give you the strength to be able to take care of the baby. Her body's going through a healing process after giving birth, whether she gave birth vaginally or by C-section. So nutrition is key in that healing process. You want to make sure you eat the way you did during your pregnancy. You want to keep that, you know, during the pregnancy that the doctors and the nurses kept saying, you know, take in at least 500 calories more than what you would normally. You do the same during during your postpartum and while breastfeeding. And more so if she's breastfeeding, because she needs that nutrition for the body to have the energy to be able to produce this milk for this baby.
Anna told me that the emotional benefits of Meals for Moms is also very important to new parents.
Emotionally, for a new mom, for one, she could see that there's someone else that's caring for her, that it's something that she does not have to be concerned for herself. It's very nurturing, especially if it's women to women.
As usual, Nicole packs up dinner for delivery to that week's mom.
So that is dish number 2. Those are really hard to close. Okay, not too much, but
amazing.
There you go. All yours. Congratulations on your baby.
Thank you so much. I can't wait to eat this.
Those are yum. What are you doing, track star?
Delicious.
Be careful.
I wish that we were a part of this my first time around, because that I think was even more challenging as the baby cries.
So there's one meal a week, which is always great. You don't have to. It's there to have. You don't have to. You know, any logistics, I'll cook or get this or this, so it's really nice. And you get to meet the people in the neighborhood.
Yeah, that too. It's been really helpful.
Great.
According to the Smiths, a win-win situation all the way around. For Healthbeat Brooklyn, I'm Tati Amara.
Like sweet granola.
That's all for this month. If you want to watch past episodes of the show, go to brickartsmedia.org/BIT and then click on Healthbeat Brooklyn. And you can follow us on Facebook or Twitter on BK Independent TV. Right now, information about the programs and hospitals we've just featured is about to appear on your TV screen. Thanks for watching, and stay healthy.
Watch this and other Brooklyn Independent Television episodes online at brickartsmedia.org/BIT.